Well, thank you very much, and thanks for the invitation. I was explaining to some people that I'm having the week from hell, and this is the nice bit of it. And it's great to see so many people here. I am very passionate about the material that I'm going to be talking about today, but it's nice to see a room full of people who seem to be equally passionate about the agenda that we're trying to work on. I was saying to Alan earlier, he seems to have disappeared quite rightly. Oh no, he hasn't disappeared. That I'm one of the lucky few people who's charismatic enough to follow him. Indeed, sufficiently charismatic to put him slightly into the shade, but I wouldn't want to say that too loud. The things I want to talk about today start off really just thinking a little bit about the growing needs and limited resources and competing priorities. And you'll find that I'm correct on this and Alan is wrong on this. I see no reason why we should accept this notion that health and social care resources in a formal area will be declining. There doesn't seem to be any reason to think that's true. But I don't live with either Conservative government or Brexit worries, so I'm perhaps a little bit out of touch. But I want then to talk a little bit about what our evidence suggests about what people are looking for in the delivery of formal care services. And I'm very much, in this talk, concerned with the formal access to care and what is provided in whatever structures are there. And look a little bit about how we can sometimes get better outcomes, but possibly at lower cost. And that obviously allows room for maneuver you wouldn't otherwise have, but also looking at where there is a good case for spending more to get more, and how we can try and assemble the evidence that would allow us to do that. Then going on after that to talk slightly more generally about the whole problems of measurement and evaluation in complex settings, and trying to move from simple measurement in complex settings to trying to develop more complex measures in these more complex settings. And finally, trying to look a little bit about how we build the evidence base that allows a better discussion about what priorities should be set. Now, I think it's worth us spending a moment or two just looking at the underlying context, because it's very easy in any meeting to start off saying, we're all getting older, costs are going to go through the roof, it's all terrible. It is true that we are getting older. It is true to a small extent that costs are going up, and it isn't all awful. Not least, I'm proposing to be one of these older people, and I'm proposing to have fun while I'm causing you significant costs. So I think we need to see the positive side of this as well as the negative. But aging per se brings some increased needs, but what's more interesting is aging patterns are going to bring changing needs as well as increased needs. The amount by which pure aging brings increased costs is actually quite limited. And all the evidence is now accumulating to suggest that age does bring some increase in costs, particularly around support to allow people to live more independently. But the big driver of cost near the end of life is being near the end of life. It isn't predominantly being older. And once you take into account the effects of proximity to death as opposed to the effects of aging, the increased costs associated with an aging population are a lot more limited than many of the projections have suggested. I think this is important because if we're having a serious discussion about how we use the existing resources, but more importantly, how we argue for any additional resources, it needs to be on the basis that this is, I think, a feasible agenda. It is possible that enough resource will be available to do the things that we can demonstrate are really worth doing, as opposed to simply throwing our hands in the air and saying it's all getting totally out of control. Now, we have some other advantages in thinking about this clearly. The costs of care rise near the end of life, largely because needs get more complex. because people have multiple chronic diseases, and because these multiple chronic diseases can lead to care for each individual disease being more complicated and more difficult. But, and I think this is very important to understand, many treatments with a curative intent near the end of life in the context of multimorbidity can be shown actually to shorten rather than lengthen life and often worsen rather than improve symptoms. So when you look at what is the evidence around better decision making and better supported decision making, it can lead to a more complex case ending up being cheaper than a simpler case, because there are good decisions you make not to treat things where that treatment does not in fact bring any significant benefit and may come at some loss. And I'll talk about that a little bit more in a moment. But this really means that one of the significant needs is for more skilled decision making. And when I say more skilled decision making, I don't mean just more skilled decision makers. I mean decision making that is in total more skilled, where people are supported in the choices in ways that allows better choices to be made. And we've got some nice examples of this that I'll be discussing a little later from the work we've been doing with our colleagues in New York around how expert palliative care teams can be associated with lower costs and better outcomes for people who are seriously ill and need support near the end of life to manage their symptoms. If I'm allowed to say managing symptoms, I think I will say managing symptoms, to see if I get a little reaction. But when people have symptoms, I think it's quite a good thing to manage them. Now, this growing need for skilled decision making and appropriate ways of supporting decision making, I think brings some very interesting challenges, and I'll talk a little bit about that. And one of the things that I think is interesting about this is, in some senses, where palliative care in formal structures is well organized, it looks very much like what the rest of the health system ought to look like. That's to say, it is around trying to make better decisions that are better informed and are more individualized and are more related to the particular services that are appropriate and useful to any individual and to their family. So that I've often said the problem is the health service is out of line with palliative care more than palliative care is out of line with the health service. Because to some extent, the learning from these kinds of settings can be a Trojan horse back into other settings. I was going to start off, because you've got to start off with a joke. I was going to start off with a joke about the holistic orthopedic surgeon, who wasn't only interested in the fracture, but was interested in the whole bone. And trying to get people away from the question of the very narrow specific disease problem towards what is the best mixture that you can put together in terms of treatment and support is the kind of challenge that is like getting the orthopedic surgeon to be holistic. I can just give you a very brief example. My father-in-law died a little bit over a year ago, but previously every year we went to Ballybunion for his annual holiday. Now, if anyone wants to know what end of life feels like, it's a week in Ballybunion. And so I had to have a project, and every year my project was to try and get his drugs down to less than 8. And every year he would start the holiday on about 16. And so while they were out enjoying themselves, going to mass every morning and a little walk on the beach when it wasn't raining, but it was mainly going to mass in the morning, I would get on the web, I would look at all the drugs, and I would try, and then I would phone the geriatrician, and then I would phone the GP. And by the end of the week, we always got it down to less than 8. And by the time we had the next year's holiday, it was always up to 16 again. And he was even put on statins when he didn't have high cholesterol. It was a sort of knee-jerk reaction there. And I realized that I was dealing with geriatricians and GPs, and these are the people who are meant to think the person. They're not meant to think the particular disease, but they nevertheless managed to get into that loop. Anyway, moving on, Demographic change is often blamed for bringing down the line some sort of crisis and difficulty, but it ignores the fact that demographic change is not simply the same proportions of people in larger numbers. The whole pattern of demography is changing. Not least, men are increasing in life expectancy much more rapidly than women. And as I've pointed out in a number of fora before, the good news is the evidence suggests that men are useful. The fact that there are more men means that the proportion of single-person households in old age is falling quite rapidly. Not yet the absolute number, but the proportion of single-person households is falling. Men are catching up at, in most countries, about 1 year per decade in terms of the life expectancy. The gap is narrowing quite rapidly. This, I think, has some very important implications for the context for looking at how we support people in older age and in the period leading towards the end of life, because the proportion of them who are in two-person households is rising rapidly. And the kinds of additional supports you can put in that are useful are quite different from those you put in where people are predominantly coming towards the end of life in a single-person household with all the extra vulnerability that runs with that. We know that people who are dying use more resources, but we also know that people who are dying old use less additional resources than those who die young. Whether this is pure old-fashioned inappropriate ageism or whether it reflects better decision-making, and I think the balance of evidence suggests it is more better decision-making than inappropriate ageism. It means also, though, that the older you die, the cheaper you die. And I think any of us who are proposing to try and live a very long time and die very old, bear in mind you're doing something for your country because you're avoiding some of the end-of-life costs that might otherwise have been there. Yes, you'll incur some chronic disease management costs on the way, but you won't be nearly as expensive when you die. The evidence that I got from Canada suggests that you die at about a third off if you die at 80 rather than dying at 60. So it's a very significant prize if you can push yourself that little bit extra time. But against all of this, we have a different problem. And that is, I think, well demonstrated by a number of comments that Aileen made earlier on. We are no longer willing to accept being fobbed off. Older people don't like being told there's nothing that can be done, especially when they know there is something that can be done, and there are things that can usefully be done to support. So at the same time, we are, I think, going to be facing a rise in expectations about what formal supports and formal treatments and access to care will look like, and that will, at the same time that costs may otherwise be falling, it may be pushing for some cost to rise because expectations are rising. But when we're moving into this new world with more people surviving into older age with more complex disease, what are the particular things that change in terms of what health service responses should be? And one of the most important, I think, is that to some extent we're moving from knowing what to do to having to think about how to do it. So that process can often become more important than the actual decisions that are made. Very often there isn't a right answer to what is the balance of managing and supporting people who have got multiple chronic diseases and symptoms related to those. There isn't a simple answer, you fix all of them, because you cannot fix all of them, and fixing one makes it more difficult to fix another. So that as we're getting into more complex areas, it's more clearly the case that personal preferences and the preferences of families and preferences supported by better decision-making will often be quite diverse and quite different. And it isn't sensible to think in terms of protocols, the way that you can think about a protocol for how best you manage disease X for a person of age Y, if that's the only thing you're doing. The whole guidelines movement has brought a lot of improvements in clinical care in very narrowly defined circumstance. but there is no guideline that says how you should manage 8 simultaneous problems that are co-occurring and where the sum of the parts is not the same as, sorry, the sum is not, whatever, you know, there is a thing people say about the whole, yes, the whole is not the same as the sum of the parts. So what you're seeing here is what people are saying they're looking for when you ask people what they want in the period leading up to the end of life, talking to families and talking to individuals themselves who are approaching the end of life. An awful lot of what they're talking about is process. They want access more than they want use. They want availability often, and they want processes to be good. And again, when you listen to stories people tell of experiences, over and over again, it's a failure of process more than a failure of individual things happening that lead to the unnecessary and avoidable distress. And I think any of us who have been through the formal process of trying to support someone in the family when they're approaching the end of life, and I've had 5 instances of this nice diverse mixture of complex and relatively simple disease, different ages. In that process, more often than anything else, is what causes the difficulties. It's getting through that fog, and I'm going to talk more about that in a moment because I think it's one of the key findings around what people are looking for. We need to embrace the context of multimorbidity rather than trying to understand treating diseases in the context of a single disease, because more and more treatments are being provided and support is being provided where people have complex needs, not all of which are sensibly managed in the same way. We also have changing balance of intent. I mean, one of the things that I've really enjoyed about working with palliative care people in America is you had this great legacy of the hospice benefit. If anyone doesn't know how the hospice benefit worked, on a particular day when your doctor said you're now pretty much in the last 6 months of life, you could switch and you could get access to hospice benefits, but you had to decide not to have any curative intent treatment at the same time. So you had to switch the switch and say, I'm a dying person now, I give up all this other ambition perhaps to manage the disease process differently, I'm the symptom management person now, that's where I'm going. And the ludicrous nature of this idea, where the intent suddenly switches, has actually, I think, been very useful in getting people to focus on the overlapping intent between trying to support the overall quality of life that individuals can have, rather than looking at, is this a palliative or is this a curative intent that the interventions would have? So we've got changing balance of intent is something that people are constantly asking for, not necessarily using that language, but using language that suggests they want the best support in making choices around what treatments they do or do not go ahead with and what's the best balance of advantage to them. But more than anything else, people want timely and easy access. How many times have we've heard a bit about the weekend problem. And you know, it's rather like, I don't know if there's anyone here from Waterford, if there's anyone from Waterford, you don't have a heart attack at weekends, and preferably don't do it after 7 in the evening, because your chances of dying are significantly higher if you choose to do it out of those times. So, because there is this notion you can have an emergency service, but you switch off the emergency service at weekends and in the evening. Now, when we see it in that sort of context, it makes no sense. People don't actually choose to have heart attacks at 2:30 in the afternoon because they know access to the emergency cardiology will be so good. But that same thinking permeates an awful lot of service provision where weekend and out of hours access is difficult. And even when you do get somewhere, you don't get the somewhere that has the backup supports and skills and capacities that you're looking for. So timely and easy access, along with the general issue of process, turn out to be often much more important than you actually get to someone who has a particular facility, a particular bit of equipment, a particular skill. It's getting into a system that is supportive and appropriate and available at any given time. And obviously this means people are looking for much more personalized and individual care rather than taking a protocol-driven. Can I say the word Liverpool? No, I won't say Liverpool. That might lead to. Liverpool care pathway obviously was a very well-intended idea, and I think not a completely stupid idea, but it failed to pick up that desire people have for this process to be very much individualized. So what do people want? Well, the first 5 things I identified they wanted were no hassle, no hassle, no hassle, no hassle, and no hassle. And it was extraordinary when we were doing the choice experiments where we were asking people to make decisions hypothetically around the different packages of care. Having no hassle, that's to say, when you identified particular needs or needs were identified for you, you got there and you got there quickly and you got there to someone competent. That was much the highest rated aspect that people had. That was the thing that they really overwhelmingly wanted. Now, the comment that was made, I think, on the end of that, I thought just actually summed it up better than I could say it myself. This person said it's bad enough to be dying. They didn't have to be fighting the system and feeling unsupported in the system as they tried to access what they knew and other people knew would be useful help to manage them through a particular episode of needs. The issue around choice and decision-making, I think, is another one where there was some really quite complex patterns emerged from what people were saying. We did this through this medium of choice experiments, which is trying to give people the capacity to express their preferences, but without them being able to game it, because it's too complicated to say, I'm going to give that answer because then that will make that higher than that. It's trying genuinely to pull out people's preferences across different packages of care. And when they were performing this, the choice and the support with decision-making and the appropriate ways in which decision-making was supported turned out to be quite complicated because people did want a significant role for informal carers, and they did want informal carers to be brought very much into the processes of decisions, but they emphatically didn't want to hand over responsibility primarily to informal carers. So there was this, whereas when we asked the same questions to the informal carers, they thought that their relatives did want decision-making to be handed over to them. So there was a nice mismatch between what people wanted for themselves and what people thought that their relatives wanted. And that's not to say they were not looking for an involvement, but what they didn't want was to dump responsibility for decision-making onto their family and friends and other informal carers. The other thing that was very interesting, I think, is when you did the same exercises with younger decedents, they came out with very different patterns of desires from older ones. They wanted much more direct control. They wanted much more to be making decisions and reporting them to those who would implement them, whereas with older decedents, we were seeing more people wanting to share the decision process with professionals and be supported in the decision process, but not be left with a sort of, here's your choices, choose A, B, C, or D. They wanted to be worked through what the different options looked like. And what was particularly strong, though, for all decedents in the studies was they really wanted to minimize the stress on informal carers. And I want to come back to this in a moment because the way in which informal carers are able to do what they do seems to be crucial to the kinds of preferences that people have. The other thing that is clear from doing these kinds of exercises is that preferences change significantly over time. And people often feel they've been locked into previous choices where they don't want to be locked into choices. They wanted the choices to be reopenable at different times as their needs change. And this is very much not allowing people to be forced into a position and then left with the consequences of previous decisions. And also, there are huge differences between people whose primary disease is one of the cancers, or the primary disease is one of the neurological disorders, or the primary disease is one of the respiratory disorders, and so on. We were getting very different kinds of answers depending on the basic disease. And again, that's not surprising, given that if someone is primarily dying of a cancer but has no other very significant morbidity, then it's much clearer that the balance of intent will be to try and manage the consequences of the cancer rather than managing a whole broad range of needs that the person might have. But the other thing that keeps coming back, and the earliest studies I've done in this area, which are now more than 10 years old, had exactly the same answers that more recent ones did, and that is people want timely access to skilled services. And they would put that very high in their priorities when they're entering particularly the later end-of-life period. That's not to say they want to use those services, it's say they want to have access to it. They want a contingent access rather than necessarily a demonstrated access. Now, I think this is a real challenge to healthcare providers, because we're used to the notion that there is no difference between availability and use. We think, if it's there, the person should bloody well come and use it. We're doing it for them, so they bloody well cooperate with us and come and have the service that we tell them that is appropriate for them. What people are very much saying is, I want the availability, I want to know the access is there. And this is actually, to me, entirely unsurprising, because the main source of concern is, if I have a problem, what will happen? And people are very strongly declaring they don't want to be put in that position where they're worrying about the problem even when the problem isn't there. And it comes back to some of the things I think that Alan has been talking about earlier on, and that is that the effect of a particular problem or a particular decision isn't limited to the time when the actual crisis or actual event is happening. It can precede it by a long time. And indeed, if I said to any of you here, how would you feel about living very well and very happily for the next 35 years, and on the last 3 days of your life we'll put you in a thumbscrew and pour acid on you and make you as miserable as is possible? What are you going to do for the next 30 years? Well, you'll be saying 29 years, 364 days. Then you'll say 29 years, 363 days. You will, in some senses, be living the knowledge of inadequate access to symptom management all the time between now and then. You can rest assured I have no control over access to thumbscrews and other things of that sort. No obvious financial and administrative barriers has come through as a very strong desire people have. They just don't want to be faced with, yes, you can have that, but it's going to cost you this much, or you can have that, but it's going to be 3 weeks before that's available, or it's essentially there is no difference almost between something not being available and it being available only after an extraordinary amount of hassle to get there. I go back to my previous point about the importance of no hassle and the huge preference people have expressed for no hassle. The other thing, though, that I think is really, sorry, I'm not as clever with this machine as I thought I was. The other thing that is very interesting is the attitudes that people have expressed around how they want their informal carers and friends and family to be able to participate in support in the end-of-life period. And this, I think, is also something that's an interesting lesson, because the evidence we have shows that family and friends in the last 3 months of life spend almost exactly the same amount of time doing support tasks for their relatives, regardless of what formal care is available. They will spend almost exactly the same number of hours per week in whatever are the meeting, whatever are the needs that are identified, the time taken to transport people, to support them, to sit with them, to spend time with them, to help them with washing and dressing, whatever are the tasks that are needed. What changes when you introduce more formal care is the nature of what the family and friends do. They end up spending far more time not doing practical tasks, far more time talking, far more time sitting, far more time going on expeditions, integrating with other activities and so on. So if you like to think of it this way, there's pretty much a fixed budget of informal care support. What you add to that is the opportunity to turn that informal care support into the kinds of things that family and friends can do much better than healthcare professionals or social care professionals can do. And I think that's quite interesting because people often see these two things as being, if we do more, will family do less? And the answer seems to be no, the family will not do less, they will only do different. And almost certainly they'll do more appropriate and more useful. People are very strongly in favor of death in the right setting. And when I say the preferred setting, I don't mean a specific setting, because the preferred setting has been shown to change as time goes on. But the proportion of people who die in the preferred setting is low in most countries. It's interesting, though, and going back to the difference between the rest of the world and Limerick, in this case, Limerick is out of line with the rest of the world, rather than the rest of the world being out of line with Limerick, probably. But in Limerick, the proportion of people who die in their preferred setting is much higher than it is anywhere else in these islands. And the proportion of people dying in hospital is much lower in Limerick than anywhere else. And when you look at the pathways that people have towards death, in Limerick, they're much more likely to have been supported in various ways that have allowed them to stay at home or move into inpatient hospice facilities and support, and their families report a much better trajectory of care and much lower levels of grief and inappropriate grief and inappropriate resentment at what has happened. What's interesting to me about this is that it does turn out that dying in Limerick is marginally more expensive than dying elsewhere in Ireland. If you look at all the formal care and informal care that is supporting people in the last few months of life, but for a very small extra cost, they're having a huge difference in the number of people who are dying in inappropriate, non-preferred settings, and you've got a much lower level of, say, the avoidable types of grief happening to the families and friends. And I think this does come down to some evidence that you can buy a better death. You can have a better process that may cost a little more, but does have materially better outcomes. I put at the bottom here, I don't know, any hairdressers in the room? I do not want to be unkind about hairdressers, although I do spend most of my life getting mine cut short enough that I have to visit very rarely. I mean, some of you are obviously, from the appearance, people who go about once a week. But hairdressing and yoga, I put this down as sort of cliches of what formal support for quality of life looks like. And yes, people do want to look their best, and they do want to feel that they're supported in those kinds of ways, but they're not interested in trading those kinds of aspects with the access to good decision-making support and good access to support in terms of symptom management, if that's the choice. They're not interested in thinking about one thing until other problems have been already demonstrably better managed. Anyway, we do have evidence that in many areas, particularly where people are dying with multiple health conditions, better support for decision-making leads to lower costs near the end of life. And the study particularly that we did with Sean Morrison and colleagues in New York showed that early palliative team consultations, which I would just interpret as better organized decision support for the individuals and their families, was associated with very significantly lower costs for those who had, particularly for those who had complex needs. Those who didn't have complex needs, where there was one disease that was predominantly the cause of their ill health, it made very little difference. But where they had complex disease, it made a huge difference. And that's one of the reasons why previous studies in this area have not shown these kinds of effects, because unless you take account of the multimorbidity and try and measure the overall complexity, you don't see this pattern of very significantly lower cost. And the work that Jennifer Temmel has been doing in Cambridge, Massachusetts, shows an even more important finding, that the people who got good access to early palliative care in the sense of better supported decision-making early in the end-of-life period ended up living longer than those who didn't. So in that case, and it's only a very specific set of people, but in that set of people, you could do less, cost less, and live longer. And it's quite hard to work out the intellectual case for saying we're against that. And so there are some areas in which there is now good evidence you can achieve more and spend less. You achieve more in terms of people living a little longer and living a little better. So we do have some evidence that if you can improve the quality of decision support and decision making in this crucial near end of life period, you do see that costs can be lower and outcomes are demonstrably better. We also see that the earlier in a final period of care you provide this, the more difference it makes. So if you wait until almost the last discharge from hospital following treatment of what then becomes diagnosed as life-limiting disease, you make much less difference to the profiles of care that people get than if you do it much earlier on. So the two take-home messages there really are, if you're looking for better outcomes at lower cost, you focus this kind of support on those who have got complex disease, and you focus it relatively early in the disease trajectory. You don't wait until someone is in the final crisis period of their life. And I say all the evidence is people report better quality of life, in some cases live longer, and in all cases cost less. If people do not have complex disease, it makes very little difference whether you do or do not try and introduce more expert support for decision making from skilled teams in that area. The emerging evidence is that if you take it outside the sort of final illness period, and we've been looking very much at this sort of final illness period and what can you do, if you take it earlier than that, the pattern is much more complicated, that in some cases you can achieve a better outcome at a higher cost, in some cases you achieve a better outcome at a lower cost, but there isn't a simple pattern. And one of the problems with people living longer is, of course, they live longer. And when people live longer, we celebrate that in many ways as a good outcome, but we do, of course, have to provide certain kinds of support that does have certain costs for a longer period, and sometimes that will outweigh any lower costs of people being treated leading up to that final period of life. So I'm saying that there's good evidence that in a hospital setting, good palliative care interventions for people with complex needs will lower cost. But if you look at it in the round, the evidence is more complicated and will be very much more dependent on the wider circumstances. In the other work we've been doing, we've seen that, as I said, those who got better access to palliative care services in general, that's to say they got more access or access to a wider range of possibilities, they did tend to do better in terms of the reported quality of life and much better in terms of the reported quality of life of their relatives, but there wasn't a visible financial saving, and in some cases there was a slightly higher cost. But far fewer people died in hospital. And dying in hospital is a very crude indicator, but it's quite a good crude indicator because it suggests that people are dying in a context that has not been adequately supported in terms of trying to ensure that the different options have been made available. Of course, many people will die in hospitals, and many people will die in hospitals well. I'm not trying to make a simple point, but it's quite an interesting indicator because where people die in hospitals in larger numbers, it's typically associated with less early interventions in terms of skilled decision-making from palliative care, skilled people across all the different disciplines. The other thing that was interesting, though, is we were able to compare an area like Limerick with a very comprehensive palliative care system and network with areas that had much less well-developed services. And people thought the hospital care was quite good in other places, and they couldn't bear the hospital care in Limerick. There are two possibilities. One is that Limerick has dreadful hospitals. The other is that where people know both, they know there's a difference. And one of the problems with trying to understand people's preferences here is people only know what they know. And sometimes that means they don't understand that there are better options and better choices available. Now, I want to come on briefly to a little bit about measurement, because one of the problems in economic evaluation in palliative care is that measurement of complex needs, complex interventions, complex outcomes don't fit neatly into the kinds of boxes that people typically use for measuring outcomes in other healthcare. I think what we're increasingly seeing is that actually the problem is not the problem only in palliative care, it's that we're too simple-minded in lots of other settings as well. But if you look at the use of single index measures, in general, you don't find they seem to be in any way sensitive to differences, even though other measures show that people think there's a huge difference. So you get this paradox that you can use the EQ5D3L instrument and show absolutely no effect. And you can look at people's self-reported views of different trajectories of care, and they're chalk and cheese. So we do have good evidence that simple-minded measurement doesn't work very well. We don't know just how badly it works because there are better instruments that are available. We can test them out. But overall, this kind of knee-jerk reaction of grabbing for a generic quality of life tool and see if it makes a difference, the answer is it almost certainly won't show a difference because it's not picking up the kinds of differences in quality of life that really matter. And so the likelihood is that if you're trying just to replicate what people do in economic evaluation elsewhere, you will largely fail because you'll be unable to develop your QALYs and other outcome measures that would make you comparable with doing cataract surgery or doing open heart surgery or other things where these have been widely used. So what do we have as a challenge? We're trying to look at individualized support, which makes it much more difficult than saying, here's the intervention, because you actually don't know what the intervention is until afterwards, because you don't know where the intervention will lead if the intervention isn't simply you open that door, you let the person in, you do the procedure, they go out. Some of what you're looking for and some of the things that are valued most are contingent rather than actual. So you're having to look at availability as an outcome that is valued. And there's this complex interweaving of formal and informal care, which is critically important to understanding what people are being provided with, because one isn't the same without the other, and the patterns of each are very closely intermingled. And the other thing that makes it difficult to measure costs and outcomes is very often palliative care is a whole range of different things, a whole lot of different organizations, a whole lot of different types of people, including a lot of the types of activity that would not narrowly be defined as palliative care, and many of the ones that Alan was talking about would be in that category. So you've got a lot of background things going on, and services being provided, and support being provided, and activities being appropriate, and these are hard to measure because they don't simply collapse down into a single cost for a healthcare provider, which you can easily calibrate. Now, we know that simple outcome measures don't adequately capture this, and there's a particular problem that I think we need to address here, which is around, I'm sorry this is a slightly geeky point, and I don't mind being a little geeky occasionally, but this is about the problem of additivity of time. Because most people who do assessments of outcomes in healthcare assume that a month is a month. But you can adjust that month for whether it was a good month or a bad month. But after you've adjusted it, you can add it up with any other good or bad month, and that's fine. there's increasing evidence from very renowned psychology and economic evidence that people don't actually think like that. If you take, for example, Kahneman's idea of the peak and end rule, that's to say a 3-week holiday is not preferred to a 2-week holiday, but a 3-week holiday with a good ending is excellent. A 3-week holiday with a bad ending might be much worse than a 2-week holiday. And people don't say, my holiday was good because I had a good week plus a good week plus a good week. They think of a holiday as being good because the overall experience had some good points in it and ended well. Ending well is important. Now, I'm not a great disciple of Kahneman. I'm not saying we have to go down that route. But what it illustrates is that people don't actually add up time. They look at whole experiences and put a value on a whole experience, which may be longer or shorter. And it's not necessarily better because it's longer. But if it ends well, it's certainly better. And if it has a high point, it's certainly better. When I say a high point, I mean a sustained period of things going well. And one of the problems we have with almost all metrics that have been used for outcome measurement in health is they do assume you can add up time. I've just been recently refereeing a paper. You'll probably see it come out quite soon, and I have no idea who the authors are because I wasn't allowed to know. But what was interesting about it was they were criticizing my criticism of adding up time, and they were therefore obviously wrong. But what was most interesting about it was they didn't understand when I said you can't add up time. What I meant was you can't add up time. They kept saying, well, you can't add up time, therefore you must wait the time and then add it up. And I went back and said, the point about not being able to add up time is that it doesn't add up. People don't think about that. And it's the first time I've been 4 rounds of refereeing on a paper, and I kept saying exactly the same thing. If it can't be added up, that's the challenge. There isn't a solution saying, well, let's pretend we can add it up if we can only shut our eyes and pretend it's all fine. And I think there's a real problem with the kinds of measures that assume that time is itself the major driver. Now, of course, if I say to someone, would you like to live in good health for another 3 years or another 3 months? They almost certainly would say 3 years. I'm not trying to be over simple-minded about that, but the notion that somehow time and periods spent in a state are an adequate way of characterizing a whole trajectory of events and experiences seems to me to be missing the point. So we almost certainly need to move, if we're trying to get metrics that can be made comparable with other metrics, we almost certainly have to move away from ones that are simply based on the notion that a month is a month is a month, and you can add them together and somehow make a sensible conclusion from that. So we really need to move towards trying to think of ways of valuing whole trajectories of experience. And we also have to accept the fact that people don't all behave like economic man. You know, economic man cannot bear lexicographic preferences. I've said that just to make sure nobody in the room knows what I'm talking about. Is that correct? Who here has got lexicographic preferences? In fact, the answer is you should all be putting your hands up because you almost certainly all have lexicographic preferences. Don't ask me to think about this until I've sorted out that. Have you ever said that? Then you have lexicographic preferences, where economists want us all to have a simple view, we can compare everything with everything. Of course, we don't compare everything with everything. We manage our ability to make comparisons in a much more limited way. And all the evidence coming out of palliative care studies suggests that people really, as I say, don't talk to me about yoga and hairdressing until you've sorted out my bigger worries. Once you've sorted out my bigger worries, please come with a hairdresser. But don't bother me with worrying about, you say, okay, you're going to be in terrible pain tomorrow, but the good story is your hair is going to be the right color and you won't see the gray roots at all. And that it's very clearly people are not in that space. I just give this, the work that Jo Coast and her colleagues have been doing around trying to find capabilities approach to measuring outcomes. I don't think this has got there, but I think it's got some quite interesting ideas here where you're trying to say what people are valuing is a whole range of different dimensions. It doesn't come down to health status narrowly measured and how long you live narrowly measured. It does have a lot of these other aspects. And I think the work they've been doing will provide us with some quite useful ways of deciding what is and what isn't worth trying to collapse down into relatively simple measures. You can find it easily if you Google ice cap, you can easily find the measures and see more about them. I'm not trying to sell them, but I think they're quite an interesting move towards trying to deal with the kinds of complexity. So, a few final thoughts. Since palliative care is many different things, we should get away from the notion that we're trying to evaluate palliative care, because it would be stupid if you said, can we evaluate surgery? Okay, is surgery a good thing or a bad thing? You'd always obviously say, well, it all depends. There are hundreds of kinds of surgery. And I think when we're thinking about valuing palliative care services, when we're looking at the formal provision of funded services and looking at what they can achieve and what they should achieve, we have to evaluate the different things and the combinations of things rather than trying to value single things. We can start, though, with identifying all the things that cost us nothing or practically nothing and achieve quite a lot. And I think if we made sure that people with complex disease were well supported in the decision-making around what clinical interventions they got, that would go a long way to improving the trajectories of an experience that people have, because there is good evidence at the moment that many people are having high-cost, unnecessary, and in some cases harmful interventions for lack of a good decision process at a critical time. The metrics will always be difficult to argue in a simple sense because there are short time scales, and longer time scales are associated with better metrics in terms of conventional outcome measures. Because the interventions are complex and may not be easily defined and characterized, and because the objectives are complex and won't be easily defined and characterized. Some palliative care can extend life, and where it does that, it's very hard to argue that we shouldn't be trying to get into that space, even though it may extend life at some slight increasing cost. Some reduces cost, particularly where care needs are complex, and some improves the experiences of patients and families, and we can demonstrate that even if we don't demonstrate it using simple outcome measures. And we really need the outcome measurement tools we use at least to be clearly identifying that these are the kinds of things that are important to people. Studies show that people can and want to articulate their preferences. There is no barrier to doing research on people who are very near the end of life in terms of trying to understand their preferences and wants. People are very willing and keen. Indeed, in some cases, this may reflect loneliness that has been allowed to occur. In some cases, it's difficult to get the researcher away. I did make the great mistake once of sending into a women's hospice setting a very elegant Italian, and it turned out that he was unable to escape from that setting at any stage. And he probably is still there. I don't know. But he was so elegant, he probably was doing a useful job just wandering around in the hospice. So that was fine. But it was interesting, the enthusiasm to take part in this kind of, and to be heard was very strong. And people can articulate hierarchies of wants, of things that are more important to them and less important to them. And we can hear that evidence, and that evidence, I think, is very useful. And it keeps coming back, though. The processes and access are hugely important to people, and we so often ignore the importance of process. We think what you get to is important. It's how you get there. And those of you who want a little bit of sort of pre-lunch singing can get up and say, it's not what you do, it's the way that you do it. Can anyone put that to music? But that is clearly an important theme. So economic evaluation is trying to say what should be provided and how should it be best provided and who should get it. It's about providing evidence that allows us to identify priorities. But we can't do that in simple ways in the way we can say who should get cataract surgery, where you say, well, if it improves visual acuity by more than 38%, then you should be in, because the evidence shows that that's worth having. We are making a mistake, I think, if we try to get into that space. We need to embrace the fact we're in more complex space. And we will never have simple measures, so the fight for resources, and I think this fight will be won. I'm not pessimistic about getting better resources for well-structured, formal palliative care services. But that fight for resources will depend on us looking for ways of characterizing those aspects of improved experience that actually matter to people. A lot of it is improved experience rather than specific access to specific services. And if you have been listening, thank you very much.